Welcome to the weekly Benefit Roast, featuring Benefit Indemnity Corporation's president, Rodger Bayne. Rodger has devoted more than 30 years to understanding and developing innovative health benefits plans for large groups and groups as small as 5 employees. Our moderator is Bob Graham. Take it away, Bob.
It is Monday, my favorite day of the week, because I get to hang out with Rodger and we get to talk on our podcast/webinar about interesting topics related to self-funded insurance. And you know that gets me excited all week. By Sunday night, I actually struggled to sleep Sunday night, thinking about what we're going to do on Monday. And Rodger, you said you wanted a big opening. I'm giving you a big opening. And I've got people, Kevin is saying, I get the same way. Okay, Kevin, I'm not sure if you're honest or facetious. Susan's saying, I don't know if I go that far. Rodger, you want to jump in and say something at this point? You've been quiet for a long time.
All I can say is I hope most of the people out there listening have as much fun as you do on this.
Hey,
all I can say.
It's self-funded insurance. If we can't have fun, what good is it?
There you go.
So we're going to talk, but before we get to our topic, I want to just inform people, if you are trying to participate, we would love to have your questions, your comments. Even if you'd like to try to be on the air with us, it's not as easy as it seems for us, but we'll try to do it. But if you have questions, you can type them into that chat box or comments. We would love to read them out loud. I've got a comment from Patrick who says, wow, you are really playing it hard today, Bob. Yes, I am. But it's Monday, it's cloudy, and I'm excited for our topic, which today is micromanaging your benefits and why that's a good thing. And I will tell you, I'm not sure where we're going today because I don't really know. Mostly when you micromanage, that's a bad thing. So today we're going to find out why it's a good thing. So Rodger, what have you got to say about that? Start the ball rolling.
Well, you know, before we get started, there's one more comment on the screen. Bob Williams says he's there drinking a Venti cappuccino for our benefit roast, which is really the whole idea, the concept of this thing. So I just wanted to make sure everybody is getting their coupons to get their coffee, because clearly Bill is enjoying his. William, excuse me, is enjoying his. And if William's enjoying his and you're not, then maybe you forgot to fill out the form last week. So at the end of this podcast, or whatever you call this thing,
webinar, podcast,
yeah, whatever,
how you listen,
at the end of this, we'll make sure we get you the link again so you can send in for your coupon as well. Anyway, thanks guys. We're talking today, you know, we've been talking about self-funded health plans and healthcare in general and a whole lot of things. And one of the things that I think so many people miss is the opportunity to micromanage their health plan benefits. Micromanaging your health benefits isn't about what you cover and what you don't, although that could be a piece of it in some cases, but it's so much more about managing the healthcare spending appropriately for the right care. I was on a call the other day, for example, and I was talking to a medical manager for a leading firm in the medical management field. And this woman is a nurse practitioner, or a registered nurse, excuse me, and she's got a wealth of experience, comes from the military first, and then is in this medical management firm now, driving real change in the healthcare industry. And one of the people questioned about a consumer when the consumer calls in, a member calls in and says, hey, I've got this condition or this symptom, and my doctor says I really need to do this, and I need you guys to help me with the network and delivering a provider for that. And the nurse practitioners will use many different industry tools to go out and study the quality. They'll take a look at that condition that the patient needs, the care that the patient needs. And then they'll find local providers that are the absolute best from a quality perspective, because we believe quality healthcare means less expensive healthcare. And then we'll build a mini network around that particular episode of care and say, for your procedure, these are the 3 people you should go see. You have the option to go otherwise, but you're going to pay a deductible and coinsurance instead of getting it for free. And one of the questions that was asked is, well, how many times do people refuse that? And what's interesting to find out is that most American consumers don't refuse that because they need guidance and they need direction in their healthcare. They really don't know. A primary care doc or a specialist says, I'm going to refer you over here down the street to see somebody else you've never met for a particular need, care, procedure, surgery, or something else. It's scary. There's no second opinion there. You need to understand what you have, and you get it. And she said that in her career, she remembers about 4 of them that said, absolutely not. I'm not going to change my doc. I'm going to Dr. God, and he's going to do this procedure. 2 of them worked out perfectly fine. 1 of them came to the open enrollment the next year and said to the entire employee population that was using this methodology of care, guys, listen to these people. I refused to listen last year, and I almost died. I went to a provider that had a quality rating of 30 out of 100 because that's who my primary care doc knew and sent me to. And I had complications and nearly died. So when she tells you you got a 30 quality rating, but these 3 people I just recommended are like 90s and 96, and the facilities.
It's a big difference when it's your life.
It's outrageous, but you know, there's a trust factor. People don't understand that there are tools out there to study the quality of their healthcare delivered now. And some docs are better at some things than they are at others. And you need to see the appropriate provider at the appropriate time. So that's just one example of micromanaging your health benefits. You need to give people the tools
You as
to
the
do it.
employer.
Oh, and by the way, the 4th actually did die.
Oh, okay. That was a pleasant way to end that story.
So yeah, so out of
We're gonna have to work on how you present that story next time.
4 people that object though, and I know it sounds cynical, and unfortunately sometimes in this business our message gets kind of cynical. You know, you lose a little bit of that compassion and empathy at the moment, but when we're talking about a business discussion in this regard, yeah, we care, and that's why we want to do a better job. And sometimes it's just that important. Healthcare can be life and death. And the quality of your healthcare really is that important, but you're not necessarily getting that because you get a book that says, go to any one of these people, because that book doesn't give you any quality measure. But that's just one example of many. But what I'm trying to...
Micromanagement is a good thing, and this is what the employer does, Rodger, or what the policyholder, the person with the benefits, or both?
Well,
you moved fast and you lost me along the way.
Micromanaging your healthcare really starts at the benefit plan level. So the employer needs to drive it, and he drives it by listening. He drives it, she drives it. The employer drives this micromanagement by really listening and learning from the more innovative benefit advisors, brokers, people that are guiding and truly offering innovative components and solutions to their health plan. Now, that's not all that easy to find, but it's out there, and you really have to find it. This is your number 2 expense in most businesses. You've got salaries and you've got benefits. And aside from that, you've got the rest of your overhead.
So you're suggesting that they look at this more deeply than just, I've used one of the big companies and I'm going to use them again because I have no choice.
That's exactly correct.
And this is digging in more deeply and really understanding what your employee population and their dependents really are using in terms of their healthcare dollar, and how you can best support that within your budget. Is that a good way of capturing it?
Yeah, I think it is a good way to capture it. I mean, you're talking about what they want, use, and need.
Okay,
right?
That's easy.
So there's real clarity in what's going on. And even those groups that are self-funded today and are already paying for the benefits themselves with their own cash dollars and insuring anything beyond what they can manage, they're not using all of the most up-to-date techniques in really controlling their healthcare spend. And that's a shame. And so they've got to learn. And that's where you need the most sophisticated delivery of information, and you need to learn, and you need to hear, and you need to study. So there's a lot of things that go on in there.
And there's a huge amount of money that could be saved by doing this, right?
Yes.
In some cases, you're talking what, $600 per covered employee?
Oh yeah, but I'm talking about even different than that. I was in a meeting this morning, and the representative that we were talking to cited an example where the surgery in 3 or 4 different places was quoted at around $150,000 for a relatively complex heart surgery. And they did some work. They talked to the hospitals based on quality and price and did a little bit of negotiation, and went back to a couple of the same hospitals and got nowhere. And finally took this patient for across the state lines to another hospital, not that far away, covered $4,000 worth of travel expenses,
Okay.
and got the procedure done a better way in a better place with higher quality for $37,000.
150,000 was a couple of quotes at hospitals.
A couple of their quotes at their local hospitals.
And then another one was how much?
$37,000 complete.
So
plus $4,000 for travel.
Okay, so for those of us who don't deal with this every day, because we don't like you do, walk me through what that means for an employee and the employee, the difference there, and what happens with that money.
Well, for an employee, in many cases, if they have to travel a little bit, what the employer will do, and what the employer did in this case, was waive their $5,000 deductible.
Okay.
So the employee just saved $5,000.
Because the employer
Plus,
said, we're going to save enough money that I want to incent you to go across the state line to do this.
Right.
And that's not illegal, right?
Oh, no. This is no big
Okay.
deal. In fact, it's not even close to illegal. There's no question
Okay,
about it.
I didn't think so.
You're in Texas near the line, and instead of going to North Central Hospital in Texas, you drive over to Oklahoma.
Okay.
I mean, and you've got a better deal.
Okay.
So, and that's not even always necessary. Sometimes you're in the same facility, but it's just a function of talking and communicating.
Okay, we have a question from Amber. Does the employer get the difference between the 47,000 and the 150,000? Which is the question I wanted to ask you.
Well, depending upon the employer's health plan,
Okay.
yes.
Okay.
The employer gets either direct cash dollars for some portion of that or all of that, or a much better renewal rate.
Okay.
Right?
No matter
So,
what, they win.
Well, they win either way. Yes. If you have an employer-sponsored group health plan, fully insured, self-funded, whatever the case may be, and it has lower claims, you win. Unless you're in community rating in the ACA and it doesn't matter.
That would be the traditional insurance.
Traditional insurance under 50 employees, whole different ballgame. If you're self-funded or over 50 employees, you win.
Okay.
So the object is to get self-funded wherever you can, regardless of how large you are, even if you're a 10-life employer.
Okay.
So because then you can start managing and micromanaging your health plan, as we say in today's subject matter. So, I mean, the first element of it is a network versus no network, right?
Let me just go back. I want to be really clear. So that difference between 47,000 and 150,000, I believe, is $103,000.
Right.
The employer would some way or another see benefit from that versus traditional insurance where you would never even know that there was a difference in the cost of service, correct?
That's correct. In traditional insurance, again, if you're over 50 employees, you would know it because you get hammered on your renewal.
Because you just had someone who
Because you just had big claims, cost the insurance company $100,000 more than it could have.
But the large managed care companies doing traditional insurance, the carriers, are not going to try to lower that price from 150 to 47,000. Generally, is that I don't mean to put you on the spot, but I'm trying to understand.
They're going to work to try and get discounts.
Okay.
And they have PPO discounts, but no, they're not going to get that far.
And you're going to be working within their network at that point.
That's correct. And you're going to be working within their network, which means you might not be able to go across state lines to get that deal. Because their network might not cross state lines depending on the network. Some of the national players, yes. But if you're in Blue Cross of X state and the neighboring state has another Blue Cross organization, you get some reciprocal deals, but it's not the same. And sometimes you don't even get to do that. So
that's why you have the network, no network on the screen right now.
Right. So when we talk about network, no network, what's really the advantage? Networks are losing their effectiveness and their purpose more and more every day. The debate now is it 5 years or 10 years before we don't see a PPO that we recognize as a PPO of today?
A PPO is a preferred provider organization. And
Right.
Walk us through real quick, Rodger, what a PPO is for those who aren't intimately aware of it.
A PPO is basically a network of doctors and hospitals that have agreed to work at a discount or a lower fee structure. They've contracted for a fee structure below that of what they would call their normal retail
With
charge.
the carrier. So carrier X goes to a group of doctors and says, we'd like to work with you, or vice versa, and they set a rate that's lower than the traditional rate, slightly lower, maybe more lower, but not 47,000 versus 150,000 lower.
That's typically correct. Yes.
Okay.
So what you might see, and this is where the confusion is, okay, that it's an oversimplified matter. And again, back to the micromanagement concept. You have $150,000. Piece of that is hospital. Piece of that is surgeon. Piece of that is anesthesiology. Piece of that is the operating room. Piece of that is some other provider, right? In the world of a hospital bill, you might have a 50% discount in your PPO.
Okay.
In the world of the surgeon and the anesthesiologist, you might not. In the world of combining this into a bundled surgery service that's negotiated and warranted at that $37,000, even if you have a complication and come back, you don't pay more, you're talking about a radical difference.
You mean 47? You said 37.
37 was the number. 37 plus 4,000 travel and 5,000 waived deductibles. So you add it up, you're about 46,000 in total cost. But I mean, the differential is so clear.
Okay.
And that's what happens when you're not confined by a network. Now, I know that sounds crazy, right? Because a network,
as you said it, I'm thinking people are going to really struggle with this, but keep going.
A network has been sold as a managed care discount advantage for the last 25 years. Yeah. And it's starting to lose that punch. And now we find ourselves that a network can actually be a constraint and a tool that captures you to this network of providers and their fee structure, even though you could do better elsewhere. And that's the challenge. And that's where micromanagement comes in. You need to understand and see these things going forward in today's market. It's different than it was 10 years ago. It's different than it was a year ago.
And this is what your company and the brokers that work with your company are providing, is this information so that an employer can make a more informed decision.
Well, it's not only information. It's information, and it is all of the tools required to do that. Absolutely critical importance to make that happen.
Now, Rodger, we have a question from, apparently someone's calling in. We have a question from Erica, and Erica is saying, this doesn't sound like what I hear when there's a discussion about healthcare these days, which is really not the worst. I feel the same thing. It seems like you're describing a scenario that's almost too good to be true. So first of all, and I've got to ask you this, I don't mean to offend you, but everything you've described here is completely legal, correct?
Oh, of course.
Okay. You're talking about such big numbers of savings, it seems impossible. And in this current situation, it almost feels like, why aren't we talking about this? You know, if someone's selling gasoline for $1.99 a gallon and everyone else is selling it for $3, word's going to spread really quick that you can save $1 per gallon. The word's not spreading really quickly here. Why do you think that is? And what does that, can you imagine an employer who's probably reluctant to even walk down this road because it's going against the grain? What would you say to them? Why do you think it's this way?
I think that, let me steal a quote from a gentleman that was here this morning.
Okay.
Talking about change is easy.
Okay.
Change is hard.
Okay.
Okay. We can talk about it all day long. I've been talking about some of these models for over 4 years before we sold our first one, before anybody took us up on this and said, wait a minute, let's see what we can do. And then they start the savings. The more innovative, the more unique, the more different, the more skepticism. Bottom line is, change is hard. It is not easy. Sometimes it takes more education all the way down to the member level, the employee level. Now, if you have an employer with 100 people in a chain of fast food restaurants that are in and out, working weekends, and you're trying to make sure you get this message all the way down to that level of education on shopping their healthcare, that's a really tough challenge. So what we have that makes change different is that we start out with an idea, and then we build around that idea and say, this is how we can do it. And then we say it's not working because nobody's hearing the message. So what do we need to do to change it? And so what we need to do to change it is design benefits around it. Alter the copay, alter the deductible, require pre-certification for a surgery. And during that pre-certification part, we pick up the phone and we educate the patient. And we say then, do you know the doctor that's been recommended is a 31 out of 100 points on a quality scale?
Wow.
Are you sure this is the direction you want to go? And would you like to consider a better option? Right? And that better option might cost the same sometimes because it's simply an issue of quality.
Okay.
But we believe, again, I repeat what we said earlier, better quality typically means lower cost, because being readmitted for something a second time never saves anybody any money, and it's certainly not a healthy thing for a patient.
Okay. So Rodger, I didn't tell you this before, but I was going through some files in my house Saturday afternoon, and I came across an article I wrote in 1999 where I quoted you talking about the cost of healthcare, that until we start focusing on the cost, we're never going to control how healthcare is delivered. That was almost 20 years ago exactly. You and I were talking about that then. I wrote a column a month later talking about how we're discussing healthcare benefits, options, services, but not cost. Have we finally, almost exactly 20 years later, have we almost exactly come full circle? Because what you're describing here sounds to me a lot like you're focused solely on cost first. What does it cost and how can we get the best cost? Not let's get the best, laminated cards. Let's not make sure we cover everyone for every single possible thing. It's much more focused. Is that what you mean by micromanagement?
What I mean by micromanagement is to get the right care in the hands of the patient when they need it.
Okay, that's simple. In concept.
In concept, it is. And what you're saying about what I may have said to you 20 years ago during an interview is absolutely valid. Is we were looking to control costs then. But when I say we are talking about we few within the industry that truly understand the dynamics and the magnitude, but not we the politicians.
Okay.
We the politicians.
You're not a politician, so the
no,
politicians.
but I'm speaking in hyperbole, I guess. The politicians at that time were talking about healthcare reform because of the pre-existing condition provision.
Yep.
Or cancellation rate increases, or insurance companies making too much money, so it must be their fault.
That's
right?
Exactly what it is then.
Exactly. So that had nothing to do with it. And unfortunately, what we find in our society in America, and you see this today loudly and clearly on every TV and radio show you ever want to see, what happens is when politics get the stage, it clouds all other innovation, right?
Yeah.
It clouds it, it gets in the way. You can make great headway and you can do some of the greatest things in the world, but if all the politician is doing is talking about some other negative aspect of what you do, you get nothing. And that negative aspect is the focus. And so in that last 20 years, since that time that quote was made, we passed a dozen probably pieces of healthcare legislation and reform, and one huge one in 2010 called the ACA, the Affordable Care Act. And yet we're still looking again at the issue of cost. So when you talk to your politicians about Medicare for all, do you know what Medicare for all does? There's only one good thing about Medicare for all. They control costs. They pay you based on a diagnosis-related group. And if you do a bad job and have to come back into the hospital or don't get out of the hospital right away, Medicare doesn't pay anymore. They're paid to get the job done right.
So readmissions are a problem in that scenario. So the
readmissions
quality
are a
of care
problem in
might
that
go
scenario.
up a little bit.
The quality of care is a big issue across the board. But the advantage that Medicare has is they tell the doctors what they have to take. Right? If you're going to see a Medicare patient, this is what you're going to get paid. And so, long story short, we would be changing the face of healthcare, but not all in good ways.
In a way, though, with your self-funded and what you've described today, you're telling the doctor more of what you're going to pay because your company's negotiating with the doctors and the hospitals for a better rate. And if you're talking about under 50,000 compared to 150,000, that's a significant difference. And it sounds like that's occurring.
That is occurring and that is working, but yet you're still paying 1.6 times Medicare. But that's okay because they're billing 3.3 times Medicare and as much as 1,000% or 10 times Medicare, right? So
we went in the wrong business.
When you look at these things, well, we didn't because that's not the side of this thing I want to be on. I'd like to be on the good guy's side. But anyway, network versus no network. Is a network more confining than it is of value? That's the first decision in micromanaging your health plan. Then you look at bundled surgical procedures, right? And we were kind of talking about that earlier. It wasn't a network issue, it's a bundled surgery. You're going to this outpatient surgical facility where you have a provider that is doing this particular procedure all day, every day. It's what they do. It's what they do best. It's what they do only. They're the best at it because it's what they do. It's what they focus on. Their facility is clean. It's crisp. It's germ-free. They do all the things they need to do.
And you have documentation to support all that.
And we have quality scores by public data and access. They tell us what the quality results are for this provider. And then we can negotiate that through some of our fine vendors within the insurance industry that are service to the industry that negotiate not only with the ambulatory surgical center, but with their pathologists, their anesthesiologists, and all of these people together to get the facility, the surgeon, the anesthesiologist, the entire procedure into one bundled package. It says we're going to do it right, and if we don't, we'll do it again in the same cost.
And if I'm self-funded, would I get that information before the procedure?
Absolutely. That's the key that we talked about kind of earlier. We got to circle back to.
I'm sorry.
No, that's okay. We got to circle back to how does the employee know all this? Well, the employee picks up the phone. The doctor says, I need you to go see this doctor. The employee then calls the pre-cert number, or the physician calls the pre-cert number on his ID card. And when you call the pre-certification number to authorize a particular treatment, that's when the action starts. That's when the right provider in the world of healthcare administration and services and medical management digs in and says, okay, here's your member status. You are X years old, you're this gender, you're this height and weight, you have no other comorbidities or other illnesses, but this is what you need. We can research that. We can find out the best providers within a 25-mile radius of you. Here are the 3 best based on quality and ultimately on price. And this is going to make a great sense for you for these 3. If one of them is the one that was already recommended, great. If they're not, then we have to ask why. And we look at the one that was suggested by your primary care physician based on his anecdotal evidence, because he's not using the same tools.
Yeah.
You might play golf with a guy. You might know him from med school. Who knows what? But the reality is we need to study all of that. So that pre-certification is the triage, so to speak. Instead of just saying, yeah, it's a covered service, let's do more. Let's triage that service and let's make sure we're getting the patient the best care, the best place, the best time.
And how long does that process take? Because if you've got, God forbid, a tumor or something, you don't want to be dragging your feet to get a procedure scheduled to meet the doctor and go through that. Is this hours or days?
The goal and the mission, one of the health plan vendors that I'm working with right now that we're building a new plan with, the goal is from the day that pre-search starts to the day that they've likely already scheduled a procedure.
Okay.
Is to have that all fixed and done within that time frame so you don't have to change the date scheduled.
Okay.
Now that's a sprint and that's not always easy.
Right.
but that's doable on most things except for maybe a diagnostic like an MRI.
Right.
But you know what? If your MRI moves a day because you were scheduled by your doctor to go do it at the hospital for $3,500, when you can do it on an outpatient facility for $300, you better know about that, right?
And you'll
because you as a
probably be
patient,
willing to wait another day.
yeah, because you as a patient are going to be paying deductible and coinsurance based on $3,500 worth of cost instead of $300. So that's usually, when you're looking at those kind of outpatient diagnostic procedures, that's right within the scope of the member's cost.
Okay. Wow.
So you're now talking about out of pocket for the member. They are grateful when somebody on the other end of the phone says, look, if you go there to XX Memorial Hospital, you're going to pay $3,500 for an MRI. You can go down the street to ABC Radiology and get it for $300 under our deals. What would you like to do?
Right.
I mean, come on. These people need to know that. So bundling up surgical packages and using the pre-cert to get them in the right direction.
So we have a question from Charlie, it looks like. Yeah, Charlie says, what's my doctor going to say if I don't go to the doctor he recommends for me? Does that create headaches, and have you experienced where that's a problem?
I've not seen where that's a problem, but I would venture to say that if your physician wants to call the people on the pre-cert line and talk about the quality and talk about the actual metrics that have been studied to prove that, your doctor's going to be on board and he's going to change his recommendations in the future.
Okay. Okay. So that's have a discussion with the doctor and tell the doctor to pre-cert.
This isn't Hillary Clinton once described pre-certification as a 22-year-old LPN, licensed practical nurse in Iowa, telling your brain surgeon what he can and cannot do to practice medicine. Remember that?
Yes.
That was back in Hillary Care in the mid-90s. It's not what we're talking about here. We are talking about validated data. In fact, the federal government imposed a tax on every American worker covered by an employer health plan in the ACA just to collect data and do research to help identify these things, right? The PCORI fees.
Okay.
Patient-centered research, whatever it is, right? So those patient-centered research fees that are taxed under the ACA, that's supposed to be spent on looking at the outcome studies and the data and finding out what is the best procedure and the best treatment for certain conditions and ailments. And of course, which comes with that is, where is that best treatment being delivered?
So you're just using that data to figure out.
We're not necessarily
choices.
using that data because the private sector was doing it 10 years before the Feds started.
Okay.
So we've got better data than the Feds do. It's why it's ironic that the Feds tax the entire world of American citizens with this new tax when they could have gotten it from the private sector better, faster, and already. So but we're not going to get into that battle. So
let me ask a weird question, Rodger. If the industry was doing that 10 years ago, why weren't they using that data in this way 10 years ago?
Well, because number one, it's a small segment in the industry that was building these things.
Okay.
And number two, it's an even smaller segment of the employer population that embraces them and understands them. And sometimes, as sad as it is, employers don't react until their cost is unbearable.
Okay.
Right?
So annoying isn't unbearable.
Annoying isn't necessarily unbearable, but when they get to a point where they are absolutely sick of these healthcare costs, and each employer's threshold is different, right? So when you achieve that threshold,
or enough of your employees are coming in complaining.
Exactly.
Because they're paying $10,000 for a procedure that their friend paid $300.
And it's a very, very unfortunate thing that that's the pain point, the catalyst for action, because the action needs to be taken every day regardless of that, but that's the reality.
I see on your screen you've got pharmacy manager.
Right. So let's take a look at the next micromanagement element, right? Let's find out if your PBM or pharmacy benefit manager is making money on every drug beyond just a simple dispensing fee, right?
Okay.
There should be a fee. They got to do something to manage their business. They got to have revenue to run their business. So there's always a fee.
Overhead, they have staff, they have all that.
But if you go to the pharmacy and your pharmacy benefit manager pays $100 for a prescription drug, and charges you 120. How do you feel about that?
100 to 120 isn't too bad.
Okay, so what are they getting paid the 20 bucks for? They're already getting paid to do their service, and they can still mark up drugs? Why would we possibly call them a pharmacy benefit manager? They're a drug sales operation at that point.
Okay.
Right? Somebody told me today that PBM doesn't really mean pharmacy benefit manager. It means perfect business model. Because you can make money on every single angle. Right?
That's a good one.
It is good, but it's tragic, and it's so true. So we talked about this in other meetings, so I'm not going to belabor it today, but spread pricing, markups, rebates, getting higher rebates by not pre-authorizing prescriptions, meaning cutting them out of the pre-authorization process and just issuing the drug without questions. I mean, it's just absurd, the kind of dirty business that goes on. So you absolutely have to manage that aspect of your business.
And then drug outsourcing is now on your screen.
Drug outsourcing is on the screen because that's another vehicle that sometimes even the best pharmacy benefit managers need help from another firm to find out how to get the best manufacturers discount deals for certain incomes and social economic environments. You get lower income employees can get stuff free from the manufacturer. Nobody takes advantage of that. Sometimes you can get a drug out of Canada. Sometimes you can fly someone to Cancun to get their drug for less than it costs to get it here.
A treatment drug where they would undergo treatment typically, not go to Cancun, go to the
right. It's not necessarily
in Cancun and
no. It would be more of a refrigerated drug or something that's injectable or IV therapy, something where they have to go get it done, but they might only have to get it done once a month or once a quarter.
Okay.
And the difference, the advantage is significant that you can pay for a weekend in Cancun and airfare and travel and still save $4,000 on a prescription. It's absurd, but it's real. So those kinds of things are real important.
You have
as well.
to look into a prescription I get because I'm thinking Cancun once a month
well,
sounds really good.
We'll talk about that. That actually may be doable. We'll talk.
Wow.
And then you get the employer to pay for all the travel because they're going to save all the money on the drug. We'll get to that later. Telemedicine.
Yes.
Another way to micromanage it, right? Who is your telemedicine provider? What do you get? And what are you doing to make sure your employees utilize that?
And telemedicine is when I call if I have a cold or a cough.
Yeah,
or
you got
sneeze,
a sore throat, you got a
and it's
cough.
basic stuff that you don't really need to go to the doctor.
You might have an infected fingernail. You might have smashed it with a hammer and something's swollen and you're not sure what's going on. What do you do with it? And you're going to call doc instead of running to the urgent care center or, God forbid, the emergency room.
Yeah.
Right? The most expensive place to get healthcare in the world is the American emergency room.
Probably the least safe too.
Probably the least safe and least effective. I'm not going to get into all that, but yeah. So
you'd be in that scenario, if I go to the emergency room, I'm paying the highest possible cost for presumably not the best care because that's not really what they're set up for.
That's
if I've hit
correct.
my finger with a hammer, I'm going to wait in the waiting room for hours because I'm not bleeding. I'm not a gunshot victim.
Not only that, but you're going to wait in the waiting room for hours with a whole bunch of people that are coughing and hacking and sneezing and have staph infections or MRSA. You know, the guy next to you is sitting on with a MRSA lesion on his leg that he's coming in the emergency room finally to find out why his leg's not healing up from this infection. And you're sitting next to him worrying about your smashed thumb.
All right, I never am going to say that I look forward to this ever again after that.
I'm sorry, but this is what you. But this is
scary.
But this is what you have to look at when you look at these big things, and that's kind of why, even back to the bundled surgery concept, care in an ambulatory surgical center. I'm not going to tell you a hospital's bad and an ambulatory surgical center is good. I'm just going to ask you, what is easier to manage? A handful of rooms that specifically do this particular surgical procedure every day, or an entire hospital that has people with every ailment, illness, and disease coming in and out of the doors every day.
Right.
Which one is easier to make sure you keep disease free?
Right.
So, I mean, that's what it's all about. Now, telemedicine is all about making sure you get utilization. Let's call the doc first. Call the nurse first. If the nurse tells you to call the doc, or just call the doc. Telemedicine is still cheaper than going to urgent care or anywhere else, right? Find out what's wrong. Many times they can order the prescription right then. You go to the pharmacy, you pick it up. You never left work. You never lost time with the kids. You never lost anything except time to go to the pharmacy and pick up your prescription. And sometimes you save $1,700 worth of emergency room deductibles, copays, and coinsurance because you went there with an earache for your son over the weekend that you didn't really need to be there.
Okay.
So consider that. Medical management, huge deal. This is probably one of the #1 conversions of ideology in the healthcare world that you need to focus on today. We need to convert second surgical opinions and pre-certification, pre-authorization into medical management at that level every day. Instead of just saying, okay, we went back, we looked at your benefit book, and yes, a tonsillectomy is covered. We go back and we say, okay, doctor recommends a tonsillectomy. Tell me how many sore throats the child has had in the last year. Tell me what kind of conditions. Tell me about the child, his height, weight, health, other conditions, right? Mm-hmm. And then let's find out the 3 best pediatric tonsillectomy surgeons and facilities in your area. And let's not go to the most expensive hospital for neurosurgery in order to get a tonsillectomy.
Okay.
Right? So medical management on so many different levels. So that's one level, is that convert these other functions into a really solid quality-based triage.
Okay.
Second thing you do in medical management is you really start to work with the patients on adherence to treatment regimen, chronic medical conditions, especially if they have 2 conditions, high blood pressure and diabetes combined. Excuse me, that comorbidity means a big increase in claims costs. If you have a 3rd, you're an absolute ticking time bomb to yourself and to your health plan. So if you're too short for your weight and you have high blood pressure and you have diabetes, you need to get a treatment regimen in place and adhere to it religiously. And you need to try, if you're at all able, to change your lifestyle so that you get rid of 1 or 2 or all 3 of those conditions.
And what does medical management do to help me with that if I'm that person?
Medical management might send you a reminder every month to get your prescription filled. Or it might say, you know what, we're scrubbing the claims data from your health plan every month, and we see that you didn't fill your prescription last month. Is there a problem? Is there anything we can help you with? What can we do for you? You know, sometimes you just barely made the mortgage payment. And that $35 copayment for your prescription drug fell to the wayside. Well, I don't know too many employers that aren't going to help that employee with $35 to get the medication they need to avoid a catastrophic medical occurrence.
Or patients cutting pills in half and taking them every other day and all.
Yeah, that's reducing the dose. Yeah, exactly. So you're not getting the proper medication treatment regimen, etc.
So this is proactive intervention designed to make sure that the patient does what is needed to ensure that they're going to be healthier, with the expectation that the cost of managing them being healthier is cheaper than the cost of 1 hospital visit. Correct?
Absolutely correct.
Okay.
And so that's the idea of medical management.
And that's really not heavy-handed, right?
No, it's not heavy-handed. It's
because
actually,
if I'm the employer, I don't want, like, you know, the prescription police to be calling all my employees at work, and you know, this is not the repossession person or the bounty hunter, right?
One firm I know sends a letter to the doctor and a letter to the patient to alert both.
Okay.
Another firm uses an automated texting system, so it texts the messages because, frankly, that's what Americans apparently respond to most nowadays. Another firm automatically sends a voicemail message to a text number, to a mobile number. So the bottom line is the messages will be delivered in whatever way we can get them to the patients. But invasive is a subjective term, right? What's invasive? Some will consider even the fact that your health plan knows you're not taking a drug as invasive. Well, of course your health plan knows if you're not taking a drug. They know if you are taking it. They know if you're not taking it because they're paying the bill.
Right.
So let's disperse with all of that.
And for the employer, this is a good thing because you're helping your employees be healthy, which is going to mean they're on the job more, they're more productive. Plus, you're not paying additional healthcare costs for them to be in and out of the hospital or undergoing big treatments.
Exactly. And Bob,
because diabetes gets expensive really quick when you start to lose toes and legs.
Actually, it gets deadly.
Yeah, that too.
Diabetes becomes fatal relatively quickly when you are not properly managing it. There's no question about it. So, amputation, limbs, those kinds of things, that's the first, but death is a whole nother ballgame. Kidney failure happens as a result of untreated diabetes, and that'll kill you ultimately. And then you got to treat that. Now you're talking about dialysis on top of diabetes. It's just an ugly, ugly thing that's relatively easy to control if you do your job.
I'm not sure, having dealt with a person in my life who's diabetic, it's not that easy. It's a little more complicated than you're giving credit.
Well, let's put it this way. My best friend died at 52 years old.
Okay.
For failure to properly manage his diabetes.
Okay.
He managed his diabetes with a Snickers bar, right? Felt his blood sugar low.
It's not the American Diabetes Association methodology, I don't believe.
No. And so this particular dear friend of mine from childhood, abused himself by not treating his diabetes properly. The first major occurrence was using a Snickers bar to treat his diabetes, his low blood sugar, and then going into a diabetic shock while driving up 95 at 65 miles an hour.
Ooh.
And having an accident that left him in shock trauma for over a week.
That's expensive.
That's expensive.
Then, for those of you not in the Baltimore area, that is like the Cadillac of care, where they basically, it's thousands of dollars per hour, but they basically take people who might not have lived and make them live.
Exactly. And then, not too many years longer, he continues still not to heed the message, and ultimately ends up needing dialysis until one morning it was so bad he didn't wake up to go to his dialysis appointment. So, is it invasive to talk to diabetic patients or high blood pressure patients or obesity patients about how to make sure they do better? You know what? People shop on the internet all day long. People talk about things, and all of a sudden their web browser has ads for it, and they don't care about that, but they're going to care about somebody calling out of concern for them not taking their prescription drug.
Okay.
This is the mentality we need to change, and this is part of what I said. Talking about change, like this conversation, this is easy.
Right.
The change is hard, because you've got to talk in those realities that really hit people in a way that say, what are you thinking? And what are you objecting to? So
which
that's
is
important.
The micromanagement that you talked about at the very beginning.
That's the whole topic. We're here to micromanage your healthcare because you have to.
So Wendy has a question for us. She's saying, this sounds really great. What can I do if I'm an employee and my company's still using what you call traditional insurance?
Just call us, Wendy. I don't know that you even know who your company's broker is, but if you want to recommend to your employer to give me a call, or you want to call me and we'll talk about it, and maybe we'll schedule a conference call, whatever you can do to stimulate action. The reality is there's room for change, even though it might be hard. Let's talk about it. That's the easy part. And then if we can convince your employer that change is warranted, and we can show them that it's not about convincing them, it's about showing them. It's about doing the research, indicating what's really needed by a group to do a better job. And we can find out what they're doing today and what they're not. And before we wrap up here today, I'll give you my number so you can call me.
Okay, and I've got a comment from Patricia, who also lost a dear friend to diabetes, and says, everything you're saying is true.
Well, I didn't make it up. It's a little too close to home for me to make up, Bob. So thank you, Patricia. I appreciate that, and I feel your pain as well. It's a difficult situation.
So Rodger, I'm seeing on your screen you have one more piece of this micromanagement of your health benefits, and that's the employee assistance plan. So how does that fit in?
Well, an employee assistance plan is just another way to really help employees. It's really good in the areas of mental health. Usually an employee assistance program will have 6 mental health counseling sessions included for a relatively low price overall for the package. It will also have some financial counseling and things of that nature, so that the employee can pick up the phone, talk to somebody about whatever problems they're having in life that are creating stress. And frankly, that helps with improving their well-being. And if you improve someone's well-being, you give them more clarity of mind to stay on their prescription, more clarity of mind to eat better, more clarity of mind in general to manage,
to do their job.
And that is stay healthy for the rest of their family's sake. Right.
And we know from research that replacing an employee typically costs a year's salary, if not a year and a half salary.
That a year and a half is what I've seen.
So keeping someone on the job and healthy, someone who knows what they're doing, has been trained, and is successful in the job, really is paramount to an employer. We don't talk about that part of this much, but there is a component of this beyond all the healthcare. Just having the right people at their desks doing their job could be big for a company.
There really is, Bob. That's a really good point, because I tend to not focus on that as much, but it is really, really important. Not only does it take 1.5 times somebody's salary to replace them, some of the other data that goes hand in hand with that I've seen is that it takes over a year, or about a year, for the new employee, the replacement, to be fully integrated into the corporate culture, to be at the peak performance that the old employee was. So,
or if you believe Malcolm Gladwell, his book, The Outliers, he said you need about 10,000 hours at a task to become an expert. 10,000 hours is about 200 work days times 5 years. And I don't know if you've had this experience, but I know in most of my jobs, if I get to 5 years, suddenly everything makes sense. You know enough to know when things are wrong and what to do when they're wrong and when things are right, and you have this depth of knowledge. So an employee who's with you for 2 or 3 years and then gets really sick, beyond the healthcare and the hit that that's going to do to your healthcare, that's going to really be disruptive within your organization. And it sounds like micromanaging health benefits might be a way to get at that. And I know for a lot of employers, that's where the rubber meets the road. Healthcare is sort of out there out on the side, but productive employees at their desk every day is where they're really focused. So maybe this is an area to throw into this.
Well, and that's part of where the employee assistance program does help and kick in. It's a small piece of it, but it's a piece of it. So that's a very good point, Bob. There's a whole lot of things to be there. Well, I see we're about out of time, Bob.
We've gone long today.
We got a couple. Well, we talked. Micromanaging is a big deal, so there's a lot to do.
We've micromanaged this hour.
Anyway, we talked to a lot of folks. We got a lot of questions. There's a couple of questions on the screen that we're just not going to have time for today, so I apologize, because we do have to wrap up with a hard stop today. But on your screen now is the link you need to send in to get your $5 coupon. So if you'll go to that link, fill out the form for us, please, and send it off. When we get that form via the internet, you don't have to send anything really, just click the buttons, and we'll make sure we get your coupon out to you right away. Anyway, thank you, everyone. Bob, thank you for your moderation, and we appreciate all of you here today, and have a great day, and we'll talk to you next week. We had a topic for next week.
Not next week. Next week is a holiday.
Next week is a holiday, but we will promote
Labor Day.
We'll talk to you about
we'll
our subject matter for that one in an email coming up. Thanks, guys. Appreciate your time.
Thanks. Have a great week and enjoy the holiday next Monday.
You've been listening to the Benefit Roast, a weekly discussion sponsored by Benefit Indemnity Corporation. Employers in a wide range of fields are using employer-owned health benefits plans to deliver better benefits to their employees at a lower cost. Learn more at benefitindemnity.co. That's benefitindemnity.co. See you again next week.